um, session tonight for our conference, A Future That is Flourishing. Welcome. This conference is funded by the Developmental Disability Support Division and the New Mexico Department of Health. Just a little message from our division. The objective of our training series is to offer educational sessions that address the theme, flourishing through the lifespan. We're pleased to offer a variety of presentations point of the speakers and do not necessarily reflect the view of the Center for Development and Disability or the University of New Mexico. A little word about chat. Based on feedback from our surveys, we believe that having the chat feature disabled will optimize your learning experience. So if you do have any questions, please feel free to use the Q&A feature that's directly at the bottom of your screen. You can direct your questions pertaining to the training, questions pertaining to the training content to the presenter. Thank you. So this month we are focusing on behavior intervention. One thing that I wanted to bring to your attention is on February 4th, we will be providing a presentation where Spanish interpretation will be available. We just wanted to make sure that you knew that. And remember that if you are interested in attending any of these presentations, you will need to register for each one separately. Please note, this session is presented in webinar format. Survey to all participants tomorrow. In order to receive your certificate of completion, you will need to complete the survey. And just a reminder, our session is being recorded. There's a few resources that we would like to bring to your attention. Again, if you want to register for future presentations in the Autism Imagine training series, you can visit this link right here. If you have your camera handy, you can take a picture of the screen so you have these links. For additional information, specific to autism spectrum disorder, you can visit the Center for Development and Disability Autism portal at the link listed on the screen. If you would like any assistance in accessing autism-related resources or navigating service systems, you can contact us. The Autism Family and Provider Resource Team are here for you. Our phone number is listed 272-1852 here in Albuquerque, or we have the toll-free number. And again, the email address is listed on the screen. One of our programs within our division that we would like to highlight is our Autism Program School Services. Our school consultation program provides training and technical assistance, as well as intensive mentoring for educational teams, including members working with students with autism in New Mexico schools. Intensive mentoring includes utilizing quality indicators for autism programs and involves a relationship between CDD consultants and district classroom teams. It focuses on assessing and developing competencies in the following areas: assessment of functional and developmental skills, programming for challenging behavior, FBA and BIP development, instruction and learning environment, reinforcement schedules and functional communication, social communication and planning for LRE. For more information, please contact Patrick Blevins at his email listed on the screen. I just want to remind you that we are offering closed captioning for all our presentations. If you would like to utilize this feature, you simply choose the subtitle on the bottom and you choose to turn it on or off. If you have any technical issues, please email our IT group at hsc-cddts@salu.unm.edu. So we'd like to welcome you to this presentation entitled Take Action, Sleep and Autism. Dr. Kristin Sohl is a professor with clinical pediatrics. She's a founder and executive director with ECHO Autism, the University of Missouri Healthcare. This presentation will address the role of co-occurring conditions in autism, recognizing the role of team-based care in autism treatment, focus on a stepwise approach to sleep concerns in autism, and identify tools and resources to assess sleep in children with autism. Right, before Dr. Sohl is ready to present, we're going to do a quick survey so we can determine your role in our community. It'll just be up for maybe like 30 more seconds. We appreciate you answering this poll. Do we have the results of the poll? Oh, there they are. Great. So thank you for doing this. It helps us to gather data for our use, and we appreciate all of you being here today. On that note, I'll let Dr. Sohl take over. Thank you.
Great. It is such a pleasure to be here with all of you. And so I certainly am very excited to be here to share with you some information today about sleep and autism, a very common co-occurring condition. And so I appreciate the warm welcome. I have a lot of history with the great UNM Center for Developmental Disabilities, and so on development and disabilities. And so certainly glad to be back here and working with some folks that I dearly love and have gotten to know over the years. So very glad to be here. And I'm thankful for all that the state of New Mexico has been doing for individuals here in the state, as well as setting the bar high for those of us across the rest of the country. I am from Missouri, so I am a practicing autism specialist. And so what that means is I'm a pediatrician by training, but I spend most of my time in specialty care. And I support people with autism as well as the concern of autism really across the lifespan. So things like early diagnosis all the way from around 12 months of age, all the way through adulthood, and so into early 20s is about as old as I get at this point. But for a pediatrician, that's getting old. So, so I certainly enjoy what I do and love the clinical work that I get to do. And I'm going to share with you some of that work here. And so I'm going to go ahead and share my screen, and then we'll get started with our learning time together. There'll be plenty of time for questions and answers as we go at the end of our time today. I do really enjoy having that opportunity to take questions. And so we'll be really looking forward to that time at the end. So feel free to utilize that question and answer option here towards the throughout the time, and then we'll get through that at the end of the time we have. So I think you heard a little bit about what I'm planning to discuss, but just to recap, we're going to discuss the role of those co-occurring conditions in autism, particularly sleep, recognizing the role of team-based care in autism treatment, and then appreciate a stepwise approach and identifying tools and resources to assess sleep in children with autism. You're going to often hear me say the word children, so if you happen to be more leaning towards adulthood or adolescence, please know that these things that I'm going to talk with you about are often focused on children, but they certainly can be applied to older age groups. As a pediatrician, most everyone in my world I refer to as a child, even though they may not actually technically be a child. So it's just part of being a pediatrician. So certainly something that I want you to know, that I do believe many of these things and use many of these tools that I'm going to share with you across the age span that I take care of in my clinical practice and have used for many, many years. So one of the things that I think is important to understand, and I'm sure many of you here today, and I saw that great breadth of knowledge that we have among our listeners, it's important to know that we have much more than just those core diagnostic features of autism when we talk about autism, right? So sure, we have the DSM-5 diagnostic criteria that guides the work that we do when we're making a diagnosis, but I guarantee you there's much more to autism than just those DSM-5 diagnostic criteria. Of course, that helps us hone and refine our understanding of autism. And yet, when we think about what impacts a family's day-to-day life or the things that are happening around their family and in that individual's day-to-day being, there are many other impacts. And so certainly today we're going to focus on sleep, but there are other things to consider as well. So as we talk today about sleep, be thinking about other roles that you may play in that person's life, either as a caregiver or if you're an individual with autism or developmental disabilities. I can imagine that you understand exactly what I'm saying in some of these spaces as well. So as we think about this together, I like to think about it in the concepts of family-centered care. So when I think about taking care of individuals, it's not about me being the physician and saying what needs to happen or what needs to take place next. You know, that is something that was the practice of medicine many moons ago, but certainly now we've evolved and we understand the key concepts around shared decision-making and this importance of having a team around a family and then obviously the individual to really support and guide those decisions. And so it's much more than the individual pieces that make up those care components. And it's much more about how do we develop as a team in both the family and supporting that family and the care that we provide, but also developing the individual as they grow and they develop so that they can make their own decisions, that self-determination ability, if you will. And so as we talk through some of the things today, many of the issues that I'll bring up related to sleep also have key components rooted in family-centered care and the core concepts that we really want to bring back home and back home into the care that we provide to individuals. I like to sum this up in the concept of we're treating the whole child, not just the behaviors. Of course, there are behaviors, right? Of course, we all have behaviors and our issues that are affecting our world affect our behaviors. And yet, if you only treated my behaviors and didn't take into account the concepts or the constructs that were operating around me, that wouldn't be a very effective treatment. So for example, right, we're all living through a global pandemic, and I guarantee you, if you tried to focus in on the behavior and not the situations that were happening around my world right now, it would not be very effective, right? There's a lot of stress. There's a lot of things happening for all of us. And certainly most of us have the ability to express that stress. We have our own coping strategies. We have our ways of dealing with those different things. And sure, we may still have behaviors, right? We may be eating more. We may be sleeping more. We might be crankier than we really maybe think we need to be. But those behaviors are likely a reflection of the whole situation around us. So it's that family unit, the healthcare setting, the community setting, if we're in education, whatever, right? So I can guarantee you that my husband has a direct impact on my behavior. Ask him. Guarantee you he would agree, and I on him, and vice versa. So when we're talking about treating a child, we're not just talking about thinking about that behavior that they're exhibiting. We're talking about that whole child, and we'll talk more about, again, in direct relationship to sleep. But I think that's a really important key concept for us to keep in mind, is how is this little person interacting with their environment and vice versa? How is their environment in turn interacting back with them? How are they able to communicate their feelings, their emotions, the things that are going on around them, and how are they effectively doing that communication? Because as we know, many people on the spectrum do really struggle with that communication. So I, as a person who doesn't have a disability with particularly autism, I can communicate quite effectively. Also ask my husband. But what I do know is sometimes those behaviors that I'm exhibiting and I can effectively communicate, that can be really difficult if I can't effectively communicate. And so that's an important piece, as I know so many of you listening right now do know communication is a really important factor. All right, so let's talk about things to consider. So, like I said, we're going to focus in on sleep today, but I don't usually offer a talk, especially as a medical physician, without making sure people are well aware of the most common underlying medical conditions to at least keep an eye on. So I have zero interest what piece of the pie you hold. I think we all have a role to play in making sure that we're looking out for the care and well-being of the whole child. If you're a teacher, if you're a doctor, if you are a therapist, wherever walk of the team you're on, I think we all have a role to play. And so certainly knowing what the most common underlying conditions are really important for us to all know so we can be on the lookout. And I'll walk you through the stages that we can think about in this regard. But certainly sleep is top of the line, right? So understanding sleep and how it impacts behavior, big deal. So we'll talk about that. Constipation, though, is also another one. So constipation is the most common of the GI conditions, the gastrointestinal conditions that can impact individuals on the spectrum, but certainly there are others. Some individuals will have more chronic loose stools. Some will have other abdominal pain issues, things like that. But certainly this is a common issue. And I don't know about you, but if you've ever had belly pain related to GI or gastrointestinal issues, you don't feel so good. And your behavior may not make you feel so good either. So certainly things to consider. Seizures are more common in individuals on the spectrum, so something for us to all be on the lookout for. Of course, your classic seizures, most people aren't going to miss because they're pretty obvious, but those more subtle seizures, a staring spell type of seizure, those can be more subtle, and it is important for us to all kind of be aware of that. So if we're a team member, again, a therapist, a teacher, a parent, a neighbor, whatever that may be that your role is, you can be aware of that and know, hey, I heard that that seizures may be more common in a child with autism. I'm not going to, step outside my professional lane if I'm a teacher or I'm a paraprofessional or what have you. But I can say to the parent, you might want to get that looked at. Maybe check in with your pediatrician, check in with your doctor, ask about those things. That can be a big deal because it has direct impact on that child's health and well-being. Other things to consider: how's hearing? Has someone checked? Are we making sure that they can hear? Same thing with feeding. If their nutrition level is not to where it needs to be, are they experiencing nutritional deficiencies that can have an impact? Pica. So pica is the eating of non-food items. So that can be anything from dirt to very significant issues like staples, or I've had many patients with very concerning habits of eating concerning items. And so certainly knowing that is important. And then just knowing how to connect back to the person that can help with that, the pediatrician, the family physician, the nurse practitioner, the physician's assistant, making that connection and helping those families take that next step forward. So other things to consider: your teeth, right? So many people don't realize this, but one of the very most common diseases in childhood is something called dental caries, just the fancy word for cavities, but it is so common. And I guarantee you, you all are likely, if you're taking care of kids, you know that. You know that the health of our mouths as children is not where it should be in this country. And so unfortunately, that is something that can absolutely be a medical concern and absolutely lead to pain, discomfort, and then certainly behavior differences. Eczema, so itchy, scratchy skin, those are also things that can certainly cause behavior challenges. Staring spells, I already mentioned, abuse and neglect and trauma. All of these things are for us to consider as they impact our behavior and then therefore our development. So this little triad that I have over here as an image on the side helps us to remember that for us as humans, but then certainly as little children who maybe don't have fully developed, and we know don't have developed coping mechanisms to think about these things, certainly we need to keep our eye on that total perspective. What might be playing into that behavior? How could an underlying medical condition be impacting that development, that behavior, and vice versa? So certainly lots of things for us to keep in mind. So now digging into our hot topic for today. So thinking about ways that we can take action from our various perspectives. So again, you may be sitting here today thinking, well, I'm going to learn about sleep, but I'm not really sure what my role could or should be. But again, I'm going to give you full permission that it is part of your role. Your role is as an advocate for people on the spectrum, people with disabilities. And so hopefully you'll find a place that can be your role within this. And so certainly I'll talk about sleep and autism and kind of the information that we know about that. I'm going to give you kind of a framework to think about. So I call it the 4 A's of autism and sleep, and I'll show you how that looks. Then we'll talk about some tips for success and some treatment options related to sleep. And then again, I will definitely allow plenty of time for questions and answers. So when you look at the literature around sleep, a lot of advances have been made in about the last decade, about 10 to 12 years, really. And so we understand these intricacies and overlapping issues related to sleep and autism much better. Still have a lot of things that we still need to learn, but we do understand it a lot better. So we know that it's a lot more common than we originally understood it to be. So sleep difficulties are common. It's not just a behavior, automatically a behavior issue. So we need to understand that. We know about 50 to 80% of individuals, particularly children, but individuals with autism, have sleep difficulties. This can also lead to challenging daytime behaviors that can be a result of those sleep difficulties. And obviously, this is probably not a news flash to many, but these can certainly cause parental stress related to poor sleep in their child. Because guess what? If the kiddo is not sleeping, the parents are probably not sleeping very well either. We do know that the cause is often multifactorial, meaning, is it an extrinsic factor? Is that child having a hard time following, that nighttime routine? Is there a nighttime routine? What's going on in that environment that's impacting that child's ability to kind of naturally soothe, fall asleep, kind of fall into that natural rhythm that we as human beings tend to have? Or is it more intrinsic? Is there something in our brains? Is our pathophysiology, the big word we use, is the physiology within our brain something different in autism? There's been a lot of looking at this, and it is what we like to say, multifactorial. We don't know for sure. There's a lot of information to point us in both directions. Just like autism, we know that we don't have all of the answers about autism. We know that some people with autism have a known genetic underlying condition, meaning there's a known genetic cause to that person's of what we say is outward autism features, right? So, okay, they have autism, and we know that that genetic difference in their genome or their genetic makeup is why they're showing those symptoms of autism. But what we don't always know is why the next person, in the class doesn't have a known genetic cause. Same thing with sleep. We know that some kids on the spectrum, they sleep like a champ. Totally fine, no big deal. Go to sleep every night, no problem. Next kiddo in the same classroom, they can't fall asleep for 3 or 4 hours. They finally fall asleep after 4 hours of fighting it. They fall asleep for 2 hours and they're up for the whole entire next day. Fine, no big deal, and never seems to faze them. And they're up, not tired, never yawn, don't care, right? So what is that, right? And so what makes it so hard to study is that there is such a wide variety of individuals on the spectrum, and then kind of narrowing it down into what makes that child that I described first, who falls asleep no problem, different from the child who has a lot of difficulties falling asleep and staying asleep. So anyway, that makes it a little bit difficult to study. So let's define first what is insomnia or difficulty sleeping, right? So there's lots of different types of insomnia. And when we think about it, kind of the one we often think about is trouble falling asleep. So we refer to that as onset delay. So trouble falling asleep is a delayed onset. Trouble staying asleep is maintenance. So trouble keeping yourself asleep. And then also what falls in this category is early morning wakings or early morning awakenings. These are all categorized in a broader category of insomnia. But as you can imagine, they're treated differently, and some are easier to treat than others. And so we'll talk through some of those as well. And some have better evidence behind their treatment than others. And we'll get into that some. Now I'm going to walk you through kind of the stepwise approach for how you can look at sleep issues in children with autism. Again, I like to think about this as the 4 A's, just essentially a way to kind of frame up how you might want to approach sleep issues. It's a very simple construct, so that way anybody can help to think through this. You're going to see some pictures off to the side that are fun to look at. It's off of a favorite book. It's a little parody off of Goodnight Moon, and I have a reference to it again in the next slide, but they're kind of fun to think about, okay? So when you're asking about it, it's nice to have a structured approach to how you ask about questions, because then that's a way you can compare over time to see if what you might be doing as a treatment, whether that's a behavioral intervention, or in my case, sometimes we use medications, if we're actually making an improvement, right? So the child's sleep habits questionnaire is something that you can access. It's free. You can look at that and be able to look at a child's sleep patterns over time. Pretty straightforward. It's just a parent reported questionnaire. Some of the questions are similar to the ones I've listed here for you, but you can also ask these types of simple questions. So I like to ask these questions specifically because I want to know how long is it taking your child to fall asleep, or does your child fall asleep within 20 minutes? Here's why I think it's important to ask specific questions. I don't know how many of you are parents at all, but parents of a child with autism. But I can tell you that oftentimes, if you've been struggling with something for a long time, you may not even think it's a problem anymore. So I often like to refer to my own, I have a chronic neck pain. And, it's honestly been there for so many years. Some days I don't even remember that it's there. So if you say to me, how you doing today? Fine, right? Do you have any pain? No. And if you start to like go head to toe in a systematic fashion, and you finally get to my neck and you say, do you have any neck, how's your neck? I'll be like, oh yeah, it really hurts, like right here, and then they're kind of like, well, why did you just say no? And I'll be like, oh, I don't know. I didn't think about it, right? So it's kind of the same concept when you're talking to families who've been experiencing something for so long, they may have kind of stopped thinking about it as a problem, even though it is. Right. And so it's an important thing to kind of drill down a little bit more. So the question I like to use to get to that is, does your child fall asleep within 20 minutes? That way they have the opportunity to say, no, actually. And so some will say, no, should they? And I'll say, well, yeah, actually, let's talk about that. And it gives me an opportunity to work through how long is it taking them to fall asleep and where do we go from here? We'll get on to that in a minute. But the asking can be very helpful. It doesn't take a lot of time to ask these questions, but it does help. Where does your child fall asleep? That can give you some insight into what that bedtime routine looks like. Do you think your child gets enough sleep? Does your child wake during the night? And if so, how many times? Another really good one, right? Because if you are just like, hey, any worries about your child's sleep? Again, very easy for a parent or even a person with autism or a person in general to be like, no, I'm fine. I sleep fine, right? But again, if they're not necessarily aware of what you mean, then they may just easily say, no, I'm good. And then do they snore? So many adults snore. So many adults snore that we often kind of consider it to be normal, but in reality, it's not normal. And so it's especially not normal for children. Children really shouldn't be snoring. If they're snoring, there's something going on in their airway. What snoring represents is airway turbulence. So airway kind of your air is not flowing as well as it should be. So you might have allergies, you might have big tonsils, you might have who knows what. It's usually not a huge deal, but at the same time, it can be disrupting sleep. Doesn't automatically mean that they're going to have to be put on a medicine. Doesn't automatically mean they need surgery, but it does mean that you probably should have a little look-see up the nose or in the mouth. And so those are important things to think through. Just important opportunities for you to think about, could that snoring be impacting their sleep? Then could that sleep issue be impacting their daytime behavior, which could over time impact their development, right? So thinking about that whole triad that I was talking about in those first couple of slides, really important for us to continue to keep those things in mind. Okay, so what are some things you can be looking for? Again, no matter what type of profession or space you're coming to this talk from, these are things that you can be doing. So certainly sleep issues. If they're falling asleep during school or therapy, that's definitely a clue that they're not likely getting enough sleep. I know there could be other reasons. They might be trying to avoid a task. They might be trying to get out of something. I get that. But you also want to consider, or are they actually legitimately tired? Are they not getting enough sleep at night? What are those other things going from? So those are some clues that you can kind of keep in the back of your mind. Are they yawning all the time? Are they just yawning and they seem really tired, right? Is that a clue to something that could be going on? What about itchy, watery eyes or nose? Those are signs that maybe there are allergies at play here. Maybe there's something going on that could be impacting their sleep. Now, what if it's just itchy, watery eyes or nose in the absence of yawning and falling asleep and things like that? Should you still think about sleep? Yeah, you should, right? Because guess what? That might mean they're snoring. Because if they're itchy, watery eyes and nose, likely their nose is stuffy, which likely means they might be snoring. So those are those questions that either you can ask or you can encourage the family to say, hey, I noticed Johnny's really itchy. And he really looks like he could maybe could use a tune-up at the pediatrician's. It doesn't mean you're saying, I think there's something wrong. It's just pointing out something that could be looked at and say, he looks a little uncomfortable. Might be something good to check into. So those are important things to think about. Now, here's something you may never have heard of, but I'm going to hopefully tell you something new. And if you have heard of it, good for you. So this is something called allergic shiners or the allergic salute. So if you've had long-standing allergies, you may be very familiar with this, but these are these little darker circles under your eyes they often have a blue hue to them, because what happens is when you have a lot of chronic allergies, the pooling of your blood, so the venous, from your veins, has a blue tint. When you have your blood in your arteries, it's redder because you have more oxygen. But when it's in the veins, it's a little more blue. So anyway, as you have allergies or more chronic allergies, your sinuses can get backed up. And so that actually creates pooling of venous blood underneath your area of your eyes. And that can give this kind of blue impression. So we call that allergic shiners. That can be an indication of underlying allergies. The allergic salute is an adorable, I think, little finding, but it's from over and over and over itching your nose like this little boy in that picture, where you eventually get a little line that actually does have a fancy schmancy name, but I'll spare you that. But it's an allergic salute is what most of us refer to it as. But it's, again, repeated itching of that little nose. And so certainly something to keep an eye out for. So you can see those things. And those are things that certainly could be indicators that there might be something going on. Please don't misunderstand. I'm not saying there is, not giving you carte blanche reign to go diagnose everybody that you see, but certainly just little clues that you can think about. Okay. So, all right, you're asking your questions. Now you're looking at, some symptoms or signs that you might be able to see. Now you want to start assessing, right? And so these are some things that may or may not be in your space, but certainly still not bad idea to consider and to think about. So I like to gather data. Now, does data have to be like really, really sophisticated data? Not necessarily. So sure, in some ways, yes, but not always. So these are opportunities to get some information about other underlying things. This could be from the doctor. This could be about things like, does this child have acid reflux? Acid reflux, which is lovingly referred to as GERD, or gastroesophageal reflux disease. That's that acronym that's up there. Anxiety can also cause sleep issues. Medications can cause sleep issues, and seizures can cause sleep issues. These are other underlying medical conditions that can be causing sleep problems. So for example, if I'm going to start intervening on sleep, which I'll give you some clues about here in a minute, if I'm going to start working on a sleep routine or sleep intervention, I kind of got to know a lot of these pieces to the puzzle. Because if it's a medication that might be interrupting sleep, well, I want to know that so that I have an idea of where to start or what I need, what else could be impacting this child's sleep before I start digging in on the behavioral aspects of things. Okay, so I want to collect all that information. I'm assessing the situation, right? And then I also really love sleep logs. I think sleep logs can be helpful. So what time does the child go to his room? Everything from, sometimes we'll even start with dinner. So dinner, and then talk to me about what things look like leading up into bedtime. What time do they go to bed, to sleep theoretically, and then all the way up until morning, and what those different things look like. And we look at that over time. Sometimes that's a matter of days. Sometimes that's a matter of weeks, whatever that may look like. We also look at the environment. So what's going on? Is it hot? Is it cold? Is it dark? Is it light? We know that sometimes our kiddos really like to have some interesting bedtime associations. So I have some kids that, will not sleep with the lights off. They have to have all the lights on, and, certain scenarios have to have exactly, certain ways and certain things. And so certainly that has an impact on sleep too. And so those are important things for us to understand, those associations that our loved ones, whether it be our loved one student, our loved one client, our loved one patient, whatever context we're, again, looking at this through, what kind of associations are impacting their sleep. So those are things that we can be thinking about. Again, these cute little images are coming to you from a Goodnight iPad, which is a parody of Goodnight Moon. And I love it because it's an updated version of that wonderful book, but very much a real life, I think, for many families. So, Goodnight, huge LCD, Goodnight Wi-Fi HD TV, right? So think about all of those things that are now in our lexicon and in our environment that require us to turn off our brains and our all of those things that are around us. Okay, so the third A, so we've asked, now we're going to assess, now we're going to address, and we're going to start to think about how do we want to intervene. All right, so bedtime routine worksheet. This is something I really like. And again, I'm going to show you a toolkit that has all of these in it. So nobody panic in case you're like, where are these resources? Don't worry, they're coming. And many of you may already have some experience using them. But a bedtime routine worksheet can be fantastic because it walks you through what are stimulating aspects of the bedtime routine versus relaxing? Something I talk to my patients about all the time, especially the parents, is, I think a lot of us grew up kind of with this notion of what bedtime routines look like, or at least we kind of in our minds think about it. And so, often I hear, well, we have dinner, and then, kind of whatever happens between dinner and kind of the start of the bedtime routine. And then maybe it's bath time, brush your teeth, read a book, go to bed, right? Okay. Now, sometimes bath time is very relaxing. Sometimes it might be the most epic battle ever. So the bedtime routine helps you to actually look at the components of the bedtime routine and decide, is that element relaxing or stimulating, and helps you think about rearranging stimulating things to other areas of the day or the evening to help place more relaxing activities closer to bedtime versus right up against when you're like, now go to sleep, right? Because our bodies are not real wired like that, right? You need to kind of ease yourself into that pattern of like, now I'm ready to go to bed. And so those are important things. Believe it or not, this book I keep referencing, I have no conflicts of interest with this book. No one, nobody, I have no royalties or anything like that. I just happen to like this book, but it actually can be pretty helpful because guess what? It's a little bit of a social story for a lot of our kids. Many of our patients, our kids, have a lot of these electronics, and a lot of it is about getting them to go to bed, right? So it is, okay, good night iPad, good night TV, good night phone, good night this, good night that, good night, all of these different things, right? And they are quite fixated oftentimes on their electronic devices. And so sure, I spend a lot of time educating parents about, the importance of setting smart limits and using all kinds of different app devices to control their kids' electronics. But let's face it, parenting's hard. And even with the best of intentions, sometimes it's just hard. And so I think it's great to teach the child themselves some of those kind of self-control measures. So having a quote unquote social story, if you will, in the version of this book to be like, okay, we've got a rhythm to this. All right, here we go. Here we go. We're going to, good night, TV, good night, iPad, night, this, night, that. All right. Good night. Right. So it's a nice little social story that you can use. Again, I'm not sure if the author intended it for it to be a social story, but it's worked quite nicely for a lot of my patients. Now, also thinking about parental patterns. And now remember, this takes us back to, we're looking at the whole family, we're looking at the whole child, right? So parental patterns can be very, very, very important in addressing a sleep situation. Whether the mom or the dad comes home late, maybe they work swing shifts, maybe dad leaves early to go and work a swing shift, whatever's going on at home, that child is likely very much in tune with what's happening around them. And so I've got lots of kids who are very well aware that dad doesn't come home until 11. And I'll be gosh darned, they're not going to bed until they see dad, or until they hear his key in the door, until they know he's walked into the kitchen, whatever. And so sometimes the other family members aren't even aware that that's the reason that child isn't, finally relaxing to go to bed until those sequence of events happens. So pointing those parental patterns out can be helpful. For example, if a caregiver in the home stays up late watching TV, it's possible that that child who is in the other room, supposed to be going to bed, won't go to bed until the TV is off or on or something happens, right? So we have to think about all of those different aspects. And then again, of course, addressing underlying medical issues, treating those other underlying medical conditions can be very much important. If that child has reflux, I don't know if any of you have had heartburn, but trying to go to sleep with heartburn is no fun, especially if you can't tell anybody that it hurts. So those are things to be on the lookout for and to then treat. So those are important things to know. Now, it is important for me to make the point that there are some people on the spectrum who do have decreased sleep need. That is difficult. And I want to make the word of caution here that is kind of what we call in my field a diagnosis of exclusion, meaning you don't just immediately lead out with, well, maybe he just doesn't need as much sleep, right? So after you've kind of exhausted your other options, then you may start to think, well, this may be one of those kiddos that has difference in their, and truly this is science, clock genes. There are genes that regulate our melatonin and different aspects of how our brains go to sleep. And so it is true that there are children on the spectrum who require or have a decreased sleep need physiologically. But again, that is kind of the last resort. So those are things that we do need to think about after we've gone through a lot of other things. Now, the fourth A is adjust. I don't know if any of you have any background in quality improvement, but it's a love of mine. And so quality improvement is just a framework around how do you iteratively or repeatedly keep working on something. So this ask, assess, address, adjust isn't a one and done, right? So it's not just something you do once and then don't ever come back. You keep thinking about it with the family, or if you are a family, you keep doing it. You keep thinking about it. Okay, I'm asking, have we thought through these things? Okay, that's asked. Now, have I assessed these things? Got it. Have I addressed these things? Got it. Now, I'm going to try some stuff. I'm going to see if it works. Okay. So here's how that intervention starts to play out. You try one thing. So maybe it's, I'm going to adjust my bedtime routine by moving some of those more stimulating activities to earlier in the evening and putting the more relaxing activities later, closer to bedtime. Let's try that. We're going to give that a week, 2 weeks, whatever. You guys get to decide. That's the beauty of it. It's very flexible. It's family centered. It's family directed, family goal directed. And so that's important to set that with the family. It's not you dictating how it's going to happen. It's the family and you working together on how that's going to go. And then you track it and you see, well, are things the same? Are they better or are they worse? Right? And then you can say, well, it's a little tiny bit better, but I'm not sure if this is working enough. Okay. Then you get to make a new decision point and you say, all right, well, let's try adding this, or let's try doing that. And you do the same thing again. And so you think about it over again, you try again for another week or whatever you and the family decide. Or if you, again, are the parent, you get to decide by yourself. But if you are working with a team, which I hope that you are, then you'll have those opportunities to make what we call small tests of change. Be patient, but also really critical to make these family driven and doable. Because one thing that I definitely have learned well over the years is that if I am setting those goals and saying to the family, all right, we're going to work on this, come back to me in 2 weeks and let me know how it goes, that never works. It just never works. So it's setting the goal with the family and saying, okay, I see that your child's having a hard time falling asleep at night, and they're waking up really early. Talk to me about which one you think would be best to work on first, right? Or I see that getting to bed within an hour is the biggest issue. We've talked about these three things that seem to be the biggest issue for your child to fall asleep on, in a reasonable amount of time. Of these three things, which do you want to try working on first, right? So that's the family driving the bus. The family gets to lead that bus, because if all of a sudden I pick one, but I don't live there, it's probably not going to work out so great. So again, it's thinking about that in that family context. I do want to highlight a couple of really helpful resources. So we're going to start getting into those resource sections. So when you get done listening to me talk and we get into our question and answer time together, you can reference back. So there's a great algorithm all around the treatment of sleep. And so this is really looking at how do I think about assessing insomnia in children on the spectrum. And so certainly it'll walk you through like, okay, I do this, and then where do I go, and how do I intersect with the medical community in particular? And so again, this may have relevance to some of you, depending on your profession, and it may not have as much relevance to others, but I certainly think it'll be helpful to many of you. This is just the second page of that same algorithm, and I've made this available to you, but you can see it on the slide as well. So now thinking about sleep. Now, these are not mind-blowing interventions, okay? And I don't think they need to be. So that's really the point of thinking about what actions can we take and how do we go from there. So a lot of times it's starting simple and it's being really critically minded about being practical and thinking about how we can help. Sometimes it's also just simply explaining a typical sleep process for a human, but particularly a child. So some basics. Thinking about bedtime routines. We've talked about that a lot, so I won't continue to beat that drum. But bedtime passes can be helpful, particularly for a verbal child who has a lot of motivation to stay in bed and earn a reward in the morning. So that is fully described in a toolkit that I'll share with you. A light timer is something that I like. It's a very inexpensive intervention. So for example, for some of our patients or some of my patients or some of our kiddos that have a really hard time knowing if it's morning yet or knowing if they can get up or not, this has been very effective. So this is the scenario, right? You've got a kiddo who is like, it's like 3 a.m. and they're up and they think it's time to get up, and they just really don't understand that it's not morning. Well, you can work on that visual cue of when it's, when this light clicks on. So it's a simple old like $1, $2 timer. You plug it into the outlet, put the light in there. Again, obviously thinking and assessing safety is also very important. We talk about that with families, and you would need to do that as well, making sure it's safe to have a light in the room. I think you catch my points there. But anyway, setting that timer to come on every morning at, let's say, 6 a.m. or 7 a.m. or whatever makes sense to the family with their routine. But then you teach that child, you work with that child to, over time, learn that when the light goes on, that's the time to open the door and come out, or that's the time that they can get up, things like that, right? Those are simple visual cues that I guess I imagine many of you are well versed in using, but I don't know how many of you have thought to put it on a quick lickety split easy timer that you can get from Lowe's or Walmart or what have you, because there's a lot of great fancy schmancy ones that people sell, like $40 lights, that you can set to a timer, and those are great too. But you can also just put on a Walmart $2 timer, and it does frankly the same thing. So also though, other places to start: a calm, peaceful, predictable environment. Our bodies have a natural clock. It's set by the hormone called melatonin. And so we have a natural rhythm to our bodies, and our bodies are set to be predictable. If you think about yourself and how you naturally know that it's almost bedtime, it has a lot to do with your eating habits, your just daytime habits, believe it or not. So if you think about it, and sometimes you may just have to stop and actually think about it, but almost all of us have a very predictable bedtime routine. Our brains get used to that predictable bedtime routine. So tonight, I want you to think about it. Like, what exactly is yours? Mine is kind of silly, but and actually, if you had asked me, long ago, did I have a bedtime routine, I would have been like, no, not really. But I do, right? I do. I watch TV. Don't do that, by the way. That's technically a no-no, but that's what I do. And so I turn it off before I go to bed, but this is my routine, right? That soothes me, and I go right off to sleep. I sleep like a baby. I have zero sleep problems, but I have a clear routine, and that's how I fall asleep. And I bet most of you do as well. But kids are still learning how to self-soothe. They don't have the natural ability, just born within them, to roll over, look at the clock, and say, oh, it's not time to wake up yet. I guess I'll roll over and go back to sleep. We call that self-soothing. That's why little infants cry and are like, hello, where's my mom? And so as they learn object permanence and those types of developmental milestones, that's when they're like, get back in here, right? Like, where'd you go? Get back in here. I know you're not here now, and I want you back, right? So they haven't learned to soothe themselves, but as they develop, they learn those skills. Our kiddos with autism have a little bit harder time with that self-soothing, so we have to teach them. One of the biggest issues around sleep associations is that if you have a hard time with self-soothing, and your associated sleep lovey-dovey, whatever it is, isn't there when you roll over to find it, you're up, right? Because you have not figured out that, well, darn it, my 12,000 stuffed animals that need to be exactly where they're supposed to be next to me in that order, that's okay. I'm still tired. I'm just going to roll over and go to bed. If you have autism, and you know that the 12 stuffed animals have to be in that order in that exact thing, and they're not, guess what? You now are no longer soothed and calm and asleep. You're now up, and where's my 12th of the, or my third of the 12, and where is it, and where did it go? And the self-soothing element is not there to say, oh, well, I'll find it in the morning, right? So a lot of this is about, okay, maybe you can have one lovey, maybe not. What are the other elements? So a lot of families like to use TVs and radios and things like that in a very well-meaning attempt to soothe their child. And then in another well-meaning attempt, they come in and turn them off when they go to bed. Sadly, that's often very counterproductive. Whatever your child goes to sleep with should stay on. I know, seems strange, but it's true. Have you ever tried to fall asleep to the television, and then all of a sudden you wake up at 2 or 3 in the morning and you're like, where am I? Right? Your brain gets used to whatever it fell asleep with. And especially if you don't know really how to self-soothe, if you roll over and whatever you went to bed with isn't there, you're like, what? Where is it? right? Or wait a minute, where's Thomas the Train? I went to sleep watching Thomas the Train. Where is it? And so those things can be very disruptive and inadvertently mess up your whole sleep. So that's an important thing to understand. And then we've also already talked about the social story. And so social stories can be very powerful. Now, of course, sometimes sleep is not so easy peasy to fix. In fact, frankly, oftentimes it can be pretty tough. So referring to a sleep specialist who can look at and actually look at what we call the sleep architecture. So doing a sleep study, which is not always the simplest strategy, but it definitely can be done. And I definitely have, there are definitely plenty of children where I think getting a sleep study, an overnight polysomnography is the fancy word for it, but that overnight sleep study can be very informative. It helps us understand, what does this child's REM sleep or that sleep pattern look like? Is it what we would expect it to be? But I can tell you that there's way more kiddos that I see and take care of that I don't need polysomnography for or overnight sleep studies for than do. So those are things to know as well. And then certainly lots and lots and lots and lots of people take melatonin to help themselves sleep overnight. And I have lots of patients that we do use melatonin with. I have a whole sleep toolkit on the use of melatonin that can help you dig deeper into that if you're interested. The take-home message there is that it's an herbal over-the-counter supplement, so it's not regulated by the FDA. That's an important thing to understand. So when people ask me, well, is it safe? I don't have a lot of great answers. There are some studies that have looked at it, but it's important to understand it is not regulated by the FDA. None of our over-the-counter herbal supplements are regulated by the FDA. So that's important to know. Every single vitamin that we take is not regulated by the FDA. So important to understand, it's a billion with a B industry in the United States. All of our vitamin and natural substances are, and that's fine. I take a ton of vitamins, like that's fine. Just know what you're doing. And so understand that just because you can buy it over the counter, just because it's natural, and this goes for any of those things, doesn't make it automatically no big deal, right? And so melatonin I do use a lot. It does work well. It's a naturally occurring hormone in your brain that reacts to the day and night, the light. And so oftentimes that actually can be quite helpful. If the child is snoring, that's also very helpful to get an evaluation for and help understand if that could be something to consider as a place that could be interruptive to that child's sleep. Okay. So again, just kind of a little bit of reiterations of the things that I've mentioned, but making sure that that child has a comfortable sleep setting. I don't know about you, but if I'm ever too hot, I don't sleep so well. So making sure that that temperature is a comfortable sleep environment. Same thing with the noise level. Sometimes too quiet can be very upsetting to people, not just kids on the spectrum, but people in general. So I find recommending kind of a noise machine, a white noise machine, a pink noise. Now they have pink noise and brown noise and all kinds of interesting noise machines can be really helpful, because what that does is it kind of equalizes the noise. Every house makes different creaks and sounds and things like that. Or again, if you've got a parent up watching TV, just kind of normalizing or equalizing that noise can be very, very helpful, because again, we as adults understand that the furnace just kicked on and we were like, furnace, no big deal, roll over, fall back to sleep. Kids don't always understand that. So that furnace kicks on and they're like, okay, it's time for the day. Let's go, mom. What the heck? Why are you still in bed? And so understanding that that may actually be, interfering with your attempt at all of these interventions can be a pretty important little nugget of information. Other things that you can do during the daytime really matter, making sure that you're getting lots and lots of sunlight. So getting that child out, helping them get sunlight and exercise. Exercise is really, really important to the body. This doesn't mean they got to go run a marathon or, any of those things. Just outside being active, or inside being active for that matter, getting that physical activity, because it sets that body's natural circadian rhythm, that rhythm of our body. Same thing for mealtimes. Mealtimes are also actually pretty important in our circadian rhythm. So dinner happening at a predictable time will also help our brains to know, like, oh, okay, mealtime. That means my belly is full. All right. And those hormones will start to kick into their natural rhythm. And those are all really helpful predictors that our body can learn the pattern and go to sleep. Routine, routine, routine. I guarantee you I am only preaching to the choir when I say this, but routines matter. And visual supports for those routines are incredibly helpful. Helping parents to know how to implement a visual routine, either in picture form or object form, very helpful. And sometimes These are things that maybe a parent or a caregiver has never had a chance to learn. And so this can be oftentimes the first and foremost step when we're thinking about sleep interventions. Simple, practical, but very powerful, very helpful, and consistency. So yeah, sure. As adults, we may have a totally different routine on the weekends. Our kiddos probably not the best choice, because one thing I think we often forget is that children often don't know the difference between a Monday morning and a Saturday night, right? So those are things that are helpful for us as a grown-up of the house or the grown-up in the situation to make sure that we are providing that consistent daily drumbeat of this is what we do. This is what we do, right? So it can be really, really helpful. I already talked a little bit about this, but these are some nice strategies. I love the bedtime pass when it's appropriate. I think it can work really, really well for those kiddos that like that little bit of motivation to stay in bed and collect a little reward in the morning, and whatever that reward might be. And you can work together as a team to think about what might be motivating. This sleep urge, sleep pressure has to do with more of that circadian rhythm. So if you're interested in that, there's plenty of literature around it, but certainly there is a natural sleep urge. And again, pay attention to your own self at times where we get a second wind. That means you have not paid attention to your natural sleep urge and now you have passed it. And so you're likely are in a second wind. Our kids are the same. They're no different. So it's important to think about when and how does your child naturally get sleepy, and map onto that. So maybe it isn't that your child has to go to bed at 7 just because that's what a book said or your mom said or grandma said or who somebody said. You look at what's happening in your own child, patient, client, whatever, and think about it. Maybe they do need to go to bed an hour later. Maybe they do need to, maybe you need to look at that timing in conjunction with that individual, because we each have kind of our own rhythm. And it's important to know, and you can certainly overstay or overextend your natural sleep cycle and then enter into that sleep second wind cycle. And then you're really like, oh, shoot, right? And then you got to kind of wait again for them to get sleepy. And so certainly that's not a fun space to be when you're tired. So certainly things to consider and to keep in mind. All right, so we're going to talk a little bit about pharmacologic interventions. And so I know that some of you may be in the medical space and some of you may not, but I think it's always helpful to be informed about what might be going on across our disciplines. So thinking about this, and so certainly we always want to look at educational and behavioral approaches first. However, if you've got a completely exhausted caregiver, a completely exhausted parent, then that might be a time to say, all right, tell you what, we all need to get some rest, right? We need to get some rest. So this may be a time to think about that. We also have opportunities when caregivers really are just like, I just can't. I've got to get some sleep. Maybe the child's having significant aggression, significant other issues, and they just need you to get the child to have some sleep. Period. Now, do I have medicines in my arsenal that just knock children out? No, right? So of course, there are no safe medicines that just click somebody out. Those are things that are called anesthesia, and they're not safe, and we don't use those in outpatient settings. And so certainly we don't do that. But definitely there are risks and benefits, and that's that part of that, that shared decision making that families and their providers need to be having, and thinking about, all right, are we at that space? Is that where we need to think about, and is that the point we need to be at? Of course, we then need to revisit that as well and think about, 6 months down the road, do we pull back on that medicine and continue working on behavioral interventions? Certainly, those are things to consider. There are no FDA approved medications for the primary treatment of insomnia. So when you see children on medicine for sleep, those are being used as a secondary indication. That means there's a medicine for something else that also causes drowsiness. So it's important to understand that. It doesn't mean it's bad. That's a very common thing that people do in medicine. So physicians and prescribers use medicines for, but it is important to understand that, because what that means is they haven't been primarily studied for that specific thing. Okay, so that's an important thing to understand. So when researchers are studying a medicine, they're studying it for the use in a very specific disease or specific issue. And so right now we do not have any approved medications for the treatment of pediatric insomnia. But we do have commonly used medications like melatonin and clonidine. There are others, but those are the two most commonly used and the ones that have the most kind of safety data behind them. So when you think about this, it's really all about monitoring progress, and it's essential to really monitor. So you really want to think about how are you going to do that? Are you going to talk to your patient client? Are you going to check in with your team either in person or by the phone every couple of weeks? And then make those adjustments. That follows that same concept, those 4 A's. So you're assessing, you're asking, you're assessing, addressing, and adjusting, right? It's that adjusting that I see people forget the most, where it's kind of like, hey, here's an apple, call me in the morning, or here's a pill, call me tomorrow, whatever, those kinds of adages, right? Not so much, right? So you want to make sure you are following up. Whatever treatment you're deploying, you want to make sure that you're actually adjusting it accordingly, so that the family's not 6 months down the road being like, oh, I was supposed to check in. It's a team, right? So it's always bringing it back to that team idea. So making appropriate adjustments to the intervention when needed, assessing the support ability of the family to implement that intervention. That's also an important key. And then provisions for appropriate referrals as needed. So certainly a lot of my families really work with their therapist on sleep. That's not something that I'm not in their home every other day. They're not seeing me a couple times a week. And so certainly our teams, and what I mean by that is their community-based teams are often really the boots on the ground that are working on these aspects with families. There are fantastic tools. And so there are links in my talk here in a couple of slides, but these are just the screen grabs of them. But Autism Speaks and a group that I'm a big part of, which is the Autism Intervention Research for Physical Health organization, have been putting together toolkits for about the last decade. So there are many. They're on constipation. They're on, everything from medication. How do you decide if medications are right for your child? On and on and on and on. But these are 2 that are specific to sleep. And there's also one about melatonin. And so I love these. I use these all the time. There are actually new videos that also go with them. So for parents who are more inclined to watch a video, they also go through these in a shorter fashion. So again, if you have more families that prefer that mode of learning, then that's great for them as well. And they walk families through a lot of the things that we talked about. Many of the things I talked about today, and not many, but all, have references, right? And so I decided to put them here in one single slide. So if you wanted to dig deeper into any of this, then you certainly can. Many of these references are more of in a review category. Rather than giving you 2, 3, 4 slides of references, I chose to do it this way. That way you could have, a couple of places if you wanted to kind of get a review aspect of content, then that was certainly ways that you could do that. Now, I also wanted to highlight something that we are big believers in. We have a program and have lots of partners throughout New Mexico as well. But certainly if you are interested in learning more about how you partner across disciplines and really work on learning more about medical conditions, or work with your colleagues in ABA or OT, early intervention, whatever, we have started a program about 6 years ago called Echo Autism, and we welcome anyone. It's a no-cost program, and we are welcome to learn with us about autism and also that total person care. And so certainly we'd love to have you. This QR code does work. So if you want to take a picture of it with your phone, you can do that. It'll take you straight to the website, or you can visit the website or any of our social media. We share resources constantly about all sorts of things. And so certainly would welcome you to join us. We also have a great program about supporting families. So it's Echo Autism Family Advocates, and it's really about empowering families to be voices in their own communities and teaching them systems of care so that they can be really effective family voices and family leaders in their community. So those are the end of my really formal remarks. But like I said, I love answering questions. And so I'm more than happy to do that. So I'm going to stop sharing my screen at this point, and I'm hoping that those comments were helpful for you. But if not, or if so, either way, I'm more than happy to answer the questions that you still would like me to answer for you. So here we go. I'm ready when you are. All right, and so I know we've got some questions coming in. And so let's see, I am going to start with, let me just get my bearings real quick. All right. So great question coming in about, are there any contraindications for using melatonin? So, that's a pretty broad question, but I understand what you're getting at. And so, of course, every person would want to have a conversation with their healthcare professional to make sure that there aren't any individual level contraindications for using melatonin. in general, no, again, it's an herbal over-the-counter supplement. So we don't know a ton because there haven't been any real solid studies looking at the use of melatonin over time. Yes, there have been some studies, but have they had the rigor that the FDA requires to officially approve melatonin? No. So it's difficult for me to answer that question. I'm not trying to dodge it. I'm just trying to answer it honestly. So no, there are not, but like anything, it's something that if you try melatonin, then it's important to monitor symptoms, side effects, things like that, right? Because those are really important things to just keep an eye on, like you would do with anything. And so what I tell families whenever I'm starting a child on melatonin is I want you to keep track of, I started melatonin on this night, and the next morning his behavior was same, better, or worse, or that night's sleep felt same, better, or worse. Really looking at, doesn't have to be really minutia level data, but again, comparing, I expected his sleep to be a little better, right? But it wasn't. Or I expected his sleep to be a little better and it was actually way worse, right? So really looking at and comparing what different aspects of using that intervention happened so that we can actually have a conversation then about the effectiveness of that intervention, whether it be melatonin or something different. So again, the toolkit that is all about kind of the use of melatonin digs deeper into the information that we do know about melatonin. But in a nutshell, that's the essence of what we do know at this point. Great question. Okay, and so then another really good question is about if a child is not falling asleep within the 20-minute span, what are some other areas we could look at with the child? So great question as well. And so again, I think it's really looking at, what does that bedroom environment look like? Do they have a lot of electronic use right up until the time that they're expected to fall asleep? So kind of the assessment that I think about is bedtime routine. So the whole kind of from almost the time they get home from school, preschool therapy, whatever. So you could decide if that's the starting point or dinner. So those are kind of the two times I usually look at, and then moving forward until their stated bedtime, if you will. And looking at what that routine looks like. And the worksheet that's in the toolkit is really helpful to break that down. So looking at that, then looking at the actual room environment. So looking at, all right, what all's in here? Is every one of her favorite toys in there? Because that may not be conducive to a good night's rest. Because think about it, right? If I had every one of my favorite items next to me, well, I might be pretty tempted to hop out of bed and go play. Or I might be pretty tempted to it just would be hard for me not to want to hop up and do something if my preferred items were right there. So looking at that room environment. Then again, looking at the external household environment, what noises are likely interfering with that child's sleep? Those are all things to kind of consider as you're assessing those aspects of your child's challenges falling asleep within that context. And then again, of course, looking at those other underlying issues that could be impacting their medical health. And so those are things to think about. Anxiety is a big one, right? So if it's a new onset problem with sleep, has there been a change? Are they about to start a new school? Have they just started a new school? Is there bullying? Is there something going on in their, in their little world that's causing them to feel anxious? So they're laying there and worried. So those are all kinds of different aspects to kind of get into, right? So there's different layers that you can think about. So that in an essence is how I would consider addressing those different aspects. And I think the talk hopefully outlines a couple of those as well. Okay. All right. And so let's see. I would like to know the name for the line on the nose. I have that, and so do my kids. Sure. All right. So the reason I was trying to remember how to pronounce it. So I think it's deniers. It's a French word, and if you ask me how to spell it, I won't be able to. Hang on one second. I bet you I can quickly Google it. If you tell you what we'll do. I will try to do my best version of multitasking, but if you Google allergic salute, it'll come up. And I will also do my very darndest to answer questions and Google at the same time, which I have been known to do quite well. So I will try to get that for you, Elise, and I'll announce it once I have it. Okay. And so we'll get you that just shortly. But yes, it's common, and a lot of people have it. And once you know, you'll be like, hey, I do that all the time, and I have it too, right? And so certainly, don't worry. There's not that many people in the world that know about that, so you don't have to worry that everybody's looking at your cute little nose. I think it's adorable, so it's cute. All right, so let's look at some other great questions that are coming in. All right, so okay, so great question about a little bit more about kind of thinking about autism and whether someone may have that diagnosis. So kind of moving away from the medical conditions around sleep, but more of that primary concern about autism, which I, of course, love to talk about. So that is just fine. So let me just, in a nutshell, briefly touch on that. And then we'll get back into the sleep aspects. So when you think about autism and those core symptoms of autism, of course, we know it can look very different across the whole spectrum. But at its core, you're looking at differences, or really deficits, in social communication, and then presence of repetitive and restricted behaviors. All right, now let's break that down, because that's pretty, there's a lot of words. I don't love talking about people's deficits, but the bottom line is that's what we're going to talk about for the next few minutes. So these are things that you don't necessarily see. These are the things that the person struggles with. Things like eye contact. So these are challenges with eye contact, difficulties with nonverbal communication. Now, guess what? A middle schooler, like the question that was asked of me, so I'll read this question so everybody's on the same page. Asking if I could share various types of checklists around the process of identifying a middle school child and the differences that could indicate that she, so it's a girl, is on the spectrum, okay? So when we think about this, especially for older kids, we start to realize that, if they've made it to middle school and nobody's noticed, or maybe nobody's said that that's what's going on, well, then they probably have some skills or maybe more subtle symptoms, right? But here's the thing. When we talk about social communication, we're talking about a very human aspect of what we do. We are almost always socially communicating with our hands, with our eyes, with our bodies, with our gestures. Those are our nonverbal ways of communicating with each other. By definition, people on the spectrum have challenges with these social communications. They may have a difficult time approaching someone to start a conversation. So for example, it's not just about being shy either. So it may be like a very awkward approach. They may be up in your face and like, hey, but not really making eye contact. So it may be very awkward. It may look very different. Maybe very lack fluidness, like a fluidity about that interaction. That can go all the way from that to someone who is very much in their own quote unquote world, right? So thinking about this full spectrum, and again, I'm not going to give you the full meal, hour-and-a-half long talk that I would normally give about diagnosing autism, but that's really what we're talking about. It's how does a child make friends? And here's the deal, right? So these are constructs that we've created to describe a deviation from the typical human interaction. Now, hear what I said, right? This is a construct that we use to describe something that is different than the majority, okay? So I firmly believe that people with autism are full of incredible gifts, talents, and things to offer the rest of us that have decided to label them as having deficits. So it's important to understand. I like to really hone in on that because unfortunately, when I talk about the diagnostic criteria, it's easy for people to hear me talking about all of these deficits, and fine, that's how it's written. But it's also important to understand that those same labels, you could say about me. I talk too much. I know it. Okay, fine. Just because society hasn't labeled that as a disorder that I know of, doesn't mean that it's not equally different. right? And so it's important for us to understand that. Now, getting back to the diagnostic criteria, are there checklists? Yes, there are some checklists, but really when you're looking at trying to make that diagnosis for someone, it's not really about a checklist. The three things you need to make a diagnosis of an individual, because it's a very important thing to get right. You need clinical expertise, first and foremost. You need a comprehensive DSM-5 based interview. So you're really wanting to dig in to those DSM-5 criteria. So it's again, kind of, I gave you those broader buckets. But then you also need a direct behavioral observation. So you really want somebody who is going to be able to take their clinical expertise, look at a direct behavioral observation, and see how that individual interacts and see how that individual is looking in the context of these social constructs or these social communication observations. Those are really important components, because otherwise it's very easy to miss the mark on either direction. It's easy to be like, oh, that's autism, when in reality it was ADHD. Or, ooh, that was that. No, that's not autism, that's ADHD, right? It's very, very easy if you lack any one of those elements to miss the mark, which sets that individual up for a lot of misinformation over the course of their lifespan. So I just think it's important to understand that. Yes, there are checklists that can help you with screenings. And so those are some things that are out there. I don't use them, so I don't know that I would encourage a lot of use of, just a checklist, but you can certainly, sorry to reference Google twice in one talk, but you can certainly Google, autism symptom checklist, and you'll find some for sure, and that's okay. But I would encourage you to find a reputable, trusted source that can help you answer some of those questions. And I think that's a really important thing to do. And so certainly, I think that's a great thing that you're here to learn more, because parent and caregiver and grandma support, as I know this is about your granddaughter, is really important. So I'm glad you're here, and I think that's really important. All right, so let's go ahead and talk a little bit more about, let's see, and I'm trying to get to as many questions as we can. Give me 1 second. Okay. Sorry, 1 second. Okay, so I'm going to tackle this question about why doesn't the FDA regulate the vitamin world? This is an interesting one. So I think the answer speaks in some part to the regulations that our own kind of, it's a little bit difficult to answer, but I think it's an important question to think through. Some of it is that the vitamin world, to use that word, it does do some of its own regulations. And so they have their own kind of entities that provide their own, quote, stamp of approval, if you will, for those supplements. And so I think that is, to date, been just fine for most of society. And so I don't think that when you look at the success of people selling supplements, I don't know that there's been a lot of push to get them regulated by the Food and Drug Administration. So I think that's one answer. I'm sure there are many, many other answers, but I definitely think that's one answer, right? So it's a consumer-driven market, and I think that's where you'd find a lot of the answers lying. And yet on the pharmaceutical side, there's a lot of it that's a much different market, right? So in order to actually get a pharmaceutical to market, it's a completely different regulatory process. And so that's really where the process lies. You're taking natural substances and bringing those to market versus pharmaceuticals and trying to bring those to market. So just two totally different worlds. And our infrastructure here in the United States is just not set up for the natural supplements to be in the same space. And so that's the best answer I can give you at the moment. But I definitely think it's an interesting one. And I've often wondered that same thing myself, because it's actually not something I always knew. And so that was certainly something that the further along in my career, the more I became more aware of that. And I find it really interesting. And so it's something I think it's important to raise awareness about. Not necessarily a bad thing. I just think it's an important thing to know. Okay. All right. Great question coming in about melatonin. So let's talk a little bit about that. And so the question is, how should we use melatonin? And so this is a good question. So what you'll see is that most commonly, you'll want to use it. I always like to say start with the lowest dose and go slow. So that's kind of the rule of thumb in any kind of pediatric prescribing. Start low, go slow, especially in autism. For whatever reason, you could ask probably any child and adolescent psychiatrist or any person who, like myself, who works with and prescribes a lot for people on the spectrum. People with autism have a different way of metabolizing medications. And so you have to sometimes use more, sometimes use less. And so it's important to be very cautious. We don't have all the answers as to why that is the case. We just know by clinical experience that it is. So following that same mantra of start low, go slow, usually I recommend to fellow prescribers that you start low at about 1 milligram. That's usually your lowest dose, about 1 milligram, around 30 to 45 minutes before your bedtime, right? So again, if you're aiming for your child to go to bed at 8:30, let's say, then you're going to give it 45 minutes before that. Now, another word about melatonin. There are probably, I don't know, I'd venture to say 50 varieties of melatonin. I know Walmart has at least 20. And so when you look at that, that's also something to consider. I do not recommend any specific melatonin. Why? Again, goes back to the whole FDA thing, right? Because how can I? I don't have anything that I can, I don't have anything I can point to say that one is better than another, than another, than another. And sure, there are some studies, there are some that have a higher caliber of validation standards than others, but I just personally, as a practicing physician with my license, I don't get into that. So what I usually recommend to families is that you pick a brand and you stay with that brand. Of course, you can change brands over time, but I wouldn't, just pick whichever one's on sale. And so every other, month, you're going to get a different brand. Instead, I'd be like, all right, I'm going to stick with this brand, and we're going to try it. And then if you're like, man, this doesn't seem to be working, maybe we should try a different brand. That's fine. But, again, like, well, it's on sale today. I'll just get this one. A little bit of a crapshoot. And here's why, because every single formulation could be different because they're not regulated. So one milligram can be different than the next, which can be different than the next. Does it mean it is? No. But can it be? Yes. So those are important things to understand. So again, simple, straightforward message. Usually start with 1 milligram, about 30 to 45 minutes before bedtime, and increase by 1 milligram increments about every 7 to 10 days to a maximum of around 3 to 5 milligrams. So if you're a parent listening to me or a caregiver listening to me, do not go over 5 milligrams without talking to your doctor. If your doctor says go for it, that's fine. If you've already gone above that, don't panic. No one's going to get hurt. Mostly the reason for that is that it's just not very effective once you get past that 5 to 6 milligram mark. But I really feel like those decisions past that 5-6 milligram mark should be discussed with your physician. I think that, or again, nurse practitioner, physician's assistant. Those are important conversations to have because, again, why would you want to take something that you don't know if it's doing anything? So those are important things to think through. So great questions. Okay, so let's see. I'm going to talk about any pointers on helping a child attached to a lovey. As a parent, my child does not seem attached to any in particular and is still clinging to us instead at night as a lovey. Yep. Wanting to be held or have mom or dad within reach at age 3. So absolutely super common. And I think that some of this is a very, very, very common scenario. Also kind of frankly, pretty common for 3-year-olds in general. So you are certainly not alone. And I hope that's reassuring in and of itself. And yet pretty tough, right? Tough on a marriage, tough on a mama. It's just tough. And so let's talk about it. There's some strategies and these are explained in the toolkit, but some one I particularly like is there's one called the rocking chair method, which is kind of a slow strategy of kind of kind of gradually moving yourself out of the bedroom. So it's kind of it's a slower extinction method. What that means is you kind of just gradually remove yourself slowly from the child. I think of it as a kind of a slow process, but if you think about the strategies that maybe your pediatricians have talked to you about when your child was a baby, like the cry it out method or, some of those, they're similar in the same essence. But when your child's 3, cry it out, a little tougher, right? Because they can move. And so, certainly it can work, but it's certainly going to be tougher. So when they're attached to you and you're trying to figure out how to get them out of your bed, that's when I think it can be useful to do a few things. You can either move them to their own room in a really exciting way. They get a new bed, they get a new something like that. And it's a big boy bed or a big girl bed, and you make a big hoopla about that new space. Sometimes that works. You'll know your kid best, whether that's going to be an option or not. I have other families who feel like what would work better is if there's a pallet on the floor, like a cot or even just a stack of blankets next to their bed where that child can still feel close, but they're not in the bed. So it's a graduated process of kind of getting that kiddo out of the bed at least. So again, these are conversations I have with my families, and we'll talk through like, what do you think? What would be a reasonable first step? So I'm always trying to think about what's a reasonable first step with a family. So again, if you're a therapist or a parent, these are things you can be thinking about. Well, man, okay, I don't know if I can get them to their room, but boy, I would love to have my bed back, right? So, all right, that might be a reasonable start. I think sometimes it's thinking through, what is it about you that they're so attached to? Sometimes it's you. All right, so then that's something we have to work on. But sometimes it's your nightgown. Sometimes it's your hair. Sometimes it's something else. So it's thinking about those issues too. And so really digging in and trying to kind of think about what those various issues are and then tweaking the behavior around it can be really useful. So I know that's a really broad answer. And I understand that may leave you feeling pretty unsatisfied, but I'm hopeful that at least that gives you a couple of avenues that you can explore. And again, the sleep toolkit does give a couple of more deeper described examples of ways that you can tackle that. And definitely know that that's a very common lovey that many families are certainly trying to work with. And it's a very common one that's tough, but certainly can be done. I will share with you very few, if any, kids sleep with their parents when they go off to college. So there's hope. It's a long way away. I'm just teasing you, but certainly there are opportunities ahead, and I can assure you that it does get better. So those are our opportunities to do that as well. Okay. All right. So let's see. So I'm trying to make sure we get a good swath of questions. Let's talk about this one. So when a child falls asleep in different places in the house, how do parents keep them in a constant area to fall asleep? Sometimes he falls asleep on the couch or the living room floor, or goes to his room and sleeps on his bed. Yep, also quite common. So this is one of those situations where this can be super disruptive. And I understand what you're saying. I understand that they're naturally falling asleep and it's kind of like, ooh, do I move him? He's asleep. Why would I bother that? Right? Or maybe it's a different scenario, but I just know from experience that's the more common one, where it's like, they're asleep. Don't touch them. And so here's what happens then, right? If they fall asleep wherever they land, number one, that's kind of setting them up for it's an unpredictable experience. And so that can lead to other issues. So what I would really encourage in this situation is to set up a visual system. And so really start to set that predictable pattern. One thing I didn't, obviously, because this isn't a talk about the diagnostic criteria, but when I talk about the diagnostic criteria and we really get to dive deep into things like repetitive and restricted behaviors and insistence on sameness, children with autism thrive on the ability to have predictability. Okay, so that's a great thing we can also capitalize on. So I can almost lay money down that if this child that you're talking about is on the spectrum, they're going to actually like the predictability of knowing that this is what's expected. I'm going to, this child's going to go to dinner and then do this and then do this, and then bedtime happens here, right? You can sleep on your bed or you can sleep on your floor, right? Either or. If then those kinds of choices can be incredibly comforting, frankly, to most of us, but definitely to people on the spectrum. Now, every child's different, so I'm not trying to say that it's a one size fits all, but by near definition, people on the spectrum like sameness. So the more that we can set up those predictable routines, the better that actually helps us with those sleep schedules and those sleep routines. So while it seems as if allowing a child to fall asleep kind of wherever may be useful, it actually usually is counterproductive. It's kind of kicking us in the tush, if you will, because it's not actually reinforcing the routine that that child really likes. So in a sense, the child is setting his own routine, but in reality, what they need are the boundaries that are being set by you so that they can learn what's going to happen next. So those are really important things for you to kind of consider as you're caring for this little person. And I will just throw this out there that this is no different than what we would do for other kids too. Any kid likes to know that there are boundaries, those guardrails on life. So when you think about a toddler, 3-year-old, right? Because terrible twos are kind of a misnomer. Threes are really where they push the limits, and then 12s and 13s. But they want to know that when they throw a monster fit, that you're there to be like, nope, right? And so they want to know that when you say bed here, you mean it. It's not bed here, 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 or here. It's bed here. So those guardrails, those boundaries are actually very comforting to children. And so, yes, they may pitch a monster fit when you say bed here. But over time, that predictability is actually incredibly comforting. And I'll also make sure that I point this out. It sets you up for future successes, because what's our goal here? Our goal here is helping an individual on the spectrum or a person with disabilities to lead a meaningful adult life, right? We don't want them sleeping wherever they land. So even that simple fact right now that probably feels like a Herculean effort to just get the child to sleep, the effort you're putting in right now to help them know where those boundaries are can actually lead to setting a path for their future, to helping them know that when they get to, middle school or whatever, they don't just get to flop down on the floor and pitch a fit, right? Or they don't just get to do X, Y, and Z. Now, I'm simplifying a lot here. Please know that I understand not all fits are about those things. I'm totally simplifying a lot. So if your child has severe challenging behaviors, I'm not minimizing those things. And yet I'm trying to make a little bit of a example out of how sometimes a lot of effort around something that seems maybe that shouldn't have a lot of consequence, like where the child falls asleep, can actually set you up for future successes down the road. And so certainly a lot can be done there with just simple things: visual schedules, social stories, clear guidelines for, nope, okay, buddy, bedtime, okay, buddy, bedtime, right? Very clear. Okay. So again, please know that I do get the full spectrum, and I do understand that sometimes what I'm saying may sound like I'm oversimplifying, and I'm trying not to, but I hope that at least that's somewhat helpful. Okay.
Dr. Sohl,
Yes, I know we're at time.
okay.
So
I didn't know what you wanted to do.
yeah, so I know we're at time. I know we still have quite a few participants. I'm happy to follow your lead. I don't want to be disrespectful of people's time that are still with us. So I can do whatever you guys would like me to do. I do want to let folks know that I will be coming back later in the year to be doing another talk. And so certainly this won't be the last time you get to see me, but I do know there are still quite a number of questions. And so happy to do whatever works for you guys.
For those that were not able to get an answer to their question, would it be okay if we gave them your email address? Maybe they could send an email to you. I don't know if that would work for your time frame, because I know you must have your plate very full right now.
Probably what would be easier, and I am not opposed to answering people's emails, except that I'm so behind on email that that's probably not going to be advantageous to anyone.
Okay.
And so I think what might be the most helpful to the group is that if one of you all can help get me the questions, then I'm happy to look at the questions and try to answer as many as I can, and then get them
Okay.
back to the group, because I'm assuming that you all probably have people's emails. Am I right about that?
I believe we do.
Let's
I
check
believe
that
that we
before we
do.
make a decision, because I want to make sure that people can get their
Okay,
questions answered.
let me find out real quick.
Okay, sounds good. You guys have been great. These questions are awesome. I'm like looking through them and they're really, really good. So tell you what, okay, I think we're about to get an answer. I was going to say I can try to answer a couple of quick ones.
I think if, Kristin, if you have time and want to answer a couple of quick ones, you don't want to take advantage of your time, but I think people would love to hear.
Yeah, you bet. Let's do that. I think that's perfectly fine. So what I'm struggling with is figuring out what I've answered and what I haven't answered. So hang on one second. So give me like 2 minutes, not even 2 minutes. When I say 2 minutes, it's like 20 seconds. Hold on a second. Okay.
Kristin,
Okay. Yeah.
I've been deleting the ones that you have answered, but there are a couple of them I can't because you wanted to answer live, and after that I couldn't.
Oh, that's what I did wrong.
So
Okay.
I wrote answered on those that you actually did answer. I may have missed one.
Got it. Not a problem. All right. Now I'm with you. I see what I did wrong. Okay, cool.
Okay.
Okay. So tell you what, let's do. So I see lots of great questions. And okay, now that I've had a chance to scroll all the way to the bottom, that's giving me a good sense of kind of common questions. So this is great. Thank you for giving me just a second to look. All right. So, okay, let's see.
Real quick, I'm sorry to interrupt you again. I was just informed that we do have the email addresses of people that have attended.
Fabulous. Excellent. Okay. Well,
Thank
the good
you.
news is I think I've digested what I needed to digest.
Okay, cool. Thank you.
All right. So let's do this. I really like this question that's about is quote, he doesn't require a lot of sleep, unquote, a cop-out answer. When my son was young, he would sleep 3 hours tops. If pain, seizures, gut have been ruled out, is it okay to medicate, such as trazodone, clonidine, things like that? I love that question. And so I want to address that question because I think it actually kind of encompasses several others. And so I want to talk about that. So this is the caveat that I would give to that question. No, it's not a cop-out answer as long as you have someone that's helping you and your team think through those various aspects. That's partially why I do talks like this, because a lot of people don't know, right? A lot of people don't understand that seizures can be affecting sleep and that, reflux can be affecting sleep and different things like that. And so it's really about all of us being informed. So when I say things like, no matter what angle, if you're a teacher, a therapist, a para, whatever, be informed, right? No, of course, I don't expect you to treat sleep if that's not your area of expertise, but I do want all of us to be informed so that we can help families know if that is something they should be thinking about. And then, all right, so let's talk about this. Of course, 3 hours of sleep is not enough. Of course, it's not enough. Now, when I think about the studies of individuals who have these unusual genes, they really are called clock genes, and there are others, but there really are clock genes. That's not a common thing, right? And it's not like I can do a blood draw to tell you if your son or daughter has a clock that has like a difference in their clock genes. I can't. Those are big research studies. These are not things that are in clinical practice. So it's not something that is even clinically useful at this point. So absolutely, once you have looked, and that's kind of why I set the talk up the way that I did, into this kind of stepwise approach of how do you look at this? How do you think about asking questions that are important to looking at sleep, right? So that everybody is at least getting their sleep assessed, asked about, and then assessed, and then addressing it in kind of a systematic way. You're looking at medical conditions, then you're looking, not then, but and you're looking at the bedtime environment, you're looking at different strategies that you can ask about. And then if the sleep is such an issue, like a 3 hour only kind of sleeping, and you've tried behavior strategies, or the behavior strategies are just too much to handle right now, because maybe there's a lot of behavior going on at home, or maybe the child's in foster care, or maybe there's so many scenarios that families struggle with, right? So many. So, I mean, too many that I could never possibly even try to cover in a minute. So whatever the case may be, that's why I tried to set it up that way. Then yes, absolutely, there's an opportunity to use medications. I only listed the two that are most common and the safest. Why? Because I don't want just anybody going to medications like trazodone, Remeron, some of these other medications, because they shouldn't just be used by anybody. And so it's partially, when I'm giving talks like this, and I do this a lot, but it's also something that I take very, very seriously, right? So I'm giving you those next best steps to help move our community forward. That community includes me. I do a ton of work with primary care, and that is a role I cherish. I'm a general pediatrician by training. I happen to practice specialty medicine, and there are plenty of phenomenal general pediatricians, family physicians who can and do safely prescribe medications like trazodone and Remeron. But there are also plenty who don't understand or know or have the experience with those medications. So I don't talk about those freely in my talks, because I don't want someone to misunderstand that, oh, she said, right? So absolutely, the bottom line is I'm giving you a stepwise approach to think about sleep, so that you as a parent, a caregiver, a teacher, a therapist, whatever, has an understanding of how to think about it. And then when you intersect with your healthcare professional, then you can have that conversation. And then I expect them to know their limits. And if they have not used or don't know how to use something like trazodone, Remeron, some of these other medicines, and by the way, those are trade names. And right this minute, I can't recall the generic name, so please don't call the CME police on me. But I can't remember. It's mirtazapine. And anyway, so in the land of medicine, right, every medicine has their generic name and then their trade name, the brand. And right this very second, I can't think of it. So apologize for that, but I can't. So sorry. But when we think about these things, I do take it very seriously, that I don't want to just be giving out, hey, did you try that? Right. So that's an important role that I take very seriously, because that's safety. And that's my, I think that's a really important thing. So I hope that's helpful. Part of what we do, and this is not a commercial for Echo Autism, because what Echo Autism is a no-cost professional development role. And what we do is try to help empower rural and underserved practitioners, whether that be medical folks or therapists or teachers or whatever, to get this kind of information, so that you can go to your pediatrician and they can say, actually, you know what? We do need to do something more than melatonin or clonidine, because 3 hours of sleep is not enough, right? And they do know how to follow that algorithm that we just talked about. So anyway, I thought that question was great, and it really does encompass so many of the other questions. That's why I'm taking such an extended time talking through it in this time we have together. So I hope many of you will recognize your own questions in these comments that I'm making here. Okay. So, all right, let me see. Okay. Okay, let's see. I'm going to take one or two more. See, I'm gonna take the one, we're gonna talk, this is a kind of a straightforward one, but I like it. So what do you know about baths in lavender? So baths in lavender, I think, is a very individual thing, right? Some people love a relaxing bath. Some people hate it. And so I think baths in lavender are individual choice. If your child finds that relaxing and soothing, have at it. Now, I will say there were some random studies that came out about 6 to 7 years ago that did draw some kind of interesting connections to overuse of lavender in baths and some unusual breast bud development in little babies. So I only throw that out there just because, like everything, moderation is important, right? So just use your heads when you're thinking about different things to do. That does not mean go throw out all of your lavender. Lavender's fine. But it's one of those things, everything in moderation. So thinking about that. And again, follow your child's lead. So if your child seems to be super perturbed by that bath, don't do it right before bedtime. If they love it and they're excited and they're playing and they're enjoying themselves, awesome. But if it's exciting, then you might want to move it to maybe before dinner or right after dinner, and then help them unwind in other ways. So those are some things to just kind of consider. So very individual, but I think baths can be very soothing to some children. So very individual, right? So I think it's things to think about. Okay. And then, all right. So then another great question about, okay, so this one I'm going to just read. So I have two children, and son sleeps like he eats in slices. Okay, a second. He chews everything, so we can't have wires, night lights, CD players. We tried battery operated forms of different strategies, but he disassembled and chewed the batteries. Yep, I've got a couple kiddos like this too. These are really tough. This is really, really tough. He needs a nightlight. He hates white noise. He only has a foam large bed, climbing mountain and walls that are chalkboards. He still finds these things. Yep. I do give him sensory chewies at night to try to help. He's a climber, a runner, an escape artist. Yep. He's on melatonin, and we do have a bedtime routine. I think he is, I think it is his biological time clock. ABA has tried to help, but we have not tried a sleep study. Can they do a sleep study on a runner? All right, great question. And absolutely, this is a definite issue, and certainly something that I experience with my patient population, and I'm sure many of you listening still also do as well. And so certainly, this is tricky. I do think a sleep study would be helpful. I would also strongly encourage you to make sure that someone on the team is looking at all of those aspects of his total little person, right? So does he have anything else going on? Have every other little aspect that we've talked about tonight been looked at? Teeth, skin. So we think about it, physicians are trained to think head to toe, right? So really looking head to toe, making sure everything's checking out. That's an important thing to think about. Can a sleep study be done on a kiddo who is a runner? Yes, and, right? The yes and comes into how well equipped is the sleep study facility. So that's something that I would encourage you to reach out to, your pediatrician or directly to the sleep team at UNM, I'm assuming is potentially where you are. If not, then definitely wherever you are. Typically, most pediatric sleep labs are able to work through some of these challenging behaviors. Not all. There also are advances in sleep studies that are coming out where you can do a home sleep study. So that can be useful. Doesn't tell you nearly as much as a actual in the overnight sleep study, but it can be pretty helpful. So there's just some things to explore. My recommendation is to first start with an appointment with a pediatric sleep specialist. Now, where do you find somebody like that? That's usually at a children's hospital. So wherever you are, checking in with again, I'd start with your pediatrician, family physician, and ask, hey, this is what's going on. I really need to have a referral to a sleep specialist. I do typically refrain from a lot of specialty referrals unless I need it. And I think in your case, that probably would be a good recommendation to really get a sense of what's going on, right? What do we need to think through? Could there be something more to this that we need to address or not? I'm not saying there is. I'm just saying I think it would warrant additional evaluation. Also, I would consider having a psychiatrist on your team if you don't already, who can really help think about the sleep behaviors from a medication standpoint to really help think through what medications could be useful in the management of your child's sleep or your children's sleep, depending on the severity of both of the kids. So that's something to really think about. And I think that would be helpful. So again, sleep specialists, start there. They'll be able to help you know if their overnight sleep study will work or not for your son. So I think that would be a good place to start. Tough situation, but definitely not uncommon either. Great question. So I think we'll stop there. I thinking I got through a good bulk of them, and I certainly am going to be looking to the team at the CDC or CDD. Sorry, the CDC is on my mind a lot lately, to help me if I've missed any major ones, and we can make sure we get to them. So thank you guys so much again for your time. I have loved being able to spend some time talking, sadly, at you. A lot of times I'm able to see some of your faces, and so I hope that this has been useful to you, and that you've enjoyed learning more about a great opportunity for us to come together and learn. So thank you so much for your time.
Kristin, thank you so much. And we just so appreciate your staying late, because we know it's 6:15 or 6:20 for you. So as we're getting into the dinner time, so we appreciate it. Our ASL interpreters, Monica and Caleb, I know we had you scheduled till 5, so we sincerely appreciate your commitment to making our continuation of the series accessible to everybody. So thank you very much. Thank you, attendees, for hanging in there, and for just so many great questions. I'm going to pop the slide up from the beginning that has our contact information on it, if you need more resources or want information, because we might have kind of left a few people hanging because we just had so many questions. We could have just been here all day with you. So thank you. As a reminder, we will be sending out an evaluation survey tomorrow. So please check your email and give us your responses. And we hope that we will be able to see everybody next week, same time, for our next presentation in this series. So thank you again, everyone. Have a wonderful evening. And this concludes our presentation for tonight. So thank you.
Thank you, everyone. Thank you, Caleb. Thank you, Monica. Thanks, Carolyn.
Thanks, Kristin.
Thanks,
Thank you,
everyone. Have a great night.
Kristen.
See you in March.
Bye, Lorianne.
Cool.
Thank you. Bye, everybody.
Bye.